Welcome back to The Deep Dive, the place where we turn massive, complex subjects into clear, actionable knowledge. We are diving deep today into one of medicine's most critical and complex challenges, managing cardiac conditions, specifically when the central pump starts to fail.
That's right. We are translating some pretty dense medical and nursing literature into an immediate understanding of how the body maintains life and, what happens when those systems break down. Our mission today is to thoroughly understand the balance between the priority concepts of perfusion, that's the delivery of blood and nutrients to the tissues, and its essential partner, gas exchange.
And the single biggest concept exemplar for this entire discussion, the perfect illustration really of what happens when those two systems collide, is heart failure. We're talking about chronic progressive pump failure here.
Yeah, heart failure, or HF. It's,
Yeah.
it's not about the heart just stopping. That's cardiac arrest. HF is about the heart failing to meet the body's metabolic demands over time. It's the inability of the heart to work effectively, leading to critically insufficient perfusion throughout the body, starving organs like the brain, kidneys, and the periphery.
And when you hear the term pump failure, it sounds catastrophic, right? But what makes this pathology so fascinating and often so self-sabotaging is the powerful, sometimes misguided way the body tries to save itself. We're going to break down that paradox today. The complex relationship between the body's short-term survival instincts and the mechanical breakdown that those very instincts actually accelerate. Okay, let's unpack this immediately. Heart failure is highly specific. It isn't just a blanket diagnosis. It's a structural or mechanical failure that has to be localized, right? The heart is essentially two pumps operating in tandem, and failure usually starts in one side before affecting the other.
Correct. Yeah, the first step in clinical understanding is always distinguishing where the failure is located, left side, right side, or occasionally a unique scenario called high output failure.
Let's focus on left-sided heart failure, LVF, first. This is the big one, the most common form. Why is this type specifically linked to both decreased tissue perfusion and severe pulmonary congestion?
Well, think of the left ventricle as the powerhouse. It pushes oxygenated blood out to the entire body. When it fails, the system immediately experiences a lack of forward flow that's decreased cardiac output. The secondary and equally dangerous problem is the back pressure. Since the blood can't move forward effectively, it backs up into the left atrium and then, crucially, into the pulmonary venous system. That backup results in fluid being pushed into the lung tissue itself, hence the pulmonary congestion.
Ah, okay. And within LVF, we have two completely different mechanisms of failure, which dictates the patient's diagnosis and eventual treatment. Let's look at function. We have the weak pump scenario,
Mhm.
systolic failure, or HFrEF. What's that?
HFrES stands for heart failure with reduced ejection fraction. This is the classic failure to, well, squeeze. The muscle just cannot contract forcefully enough during systole, the ejection phase. To qualify, the ejection fraction, EF, that's the percentage of blood ejected from the ventricle with each beat, must be reduced. Usually it drops below 40%. This directly correlates with the severity of the muscle weakness. If that EF dips below, say, 30%, those patients are often candidates for an implanted cardioverter defibrillator. The risk of a sudden fatal rhythm disturbance just increases dramatically.
So systolic failure is a problem of muscle power, the squeeze. But the second type, diastolic failure, HFpEF, seems more like a structural problem, like it reduces volume even if the squeeze looks okay.
That's a great way to put it, yeah. HFpEF is heart failure with preserved ejection fraction. The EF might even be normal, maybe over 40%. But the problem isn't the squeeze, it's the fill. The ventricle has become thickened, stiff, maybe rigid often due to long-standing chronic hypertension. During diastole, the relaxation phase, the heart can't relax and expand adequately to fill with enough blood. And if you can't fill the pump properly, you simply can't eject sufficient cardiac output, regardless of how strong the squeeze might seem. This subtype is particularly common in older adults, especially women, often with a history of untreated high blood pressure.
Okay, so LVF is all about reduced forward flow and the lungs getting congested. If the left side fails first, which you said is typical, why does the right side eventually fail too? Tell us about right-sided heart failure. RVF.
Yeah, RVF is often a consequence. It's like the domino effect of long-standing LVF. The pressure buildup in the pulmonary system, from the failing left ventricle, makes it extremely difficult for the right ventricle to push blood into the lungs. It's basically pumping against a high-pressure wall. Eventually, the right ventricle just, well, it gives up under the strain.
And when the right ventricle fails to empty completely, where does the blood back up then?
It backs up into the entire body's venous system. That's the hallmark of RVF. systemic venous congestion. So instead of fluid backing up into the lungs, it backs up into the liver, the abdomen, the legs, the neck veins. RVF can also be caused independently, mind you, by severe pulmonary hypertension or certain types of heart attacks, MIs, that specifically damage the right side.
Got it. And then there's the truly perplexing diagnosis, high output failure. That sounds like a complete contradiction.
It is. It's entirely paradoxical.
Mm.
Here, the heart muscle itself is often perfectly healthy. The cardiac output might even be normal or actually higher than normal. But the patient's metabolic demands are just so extreme, maybe due to underlying conditions like severe anemia, hyperthyroidism, or septic shock, that the heart simply cannot keep up. It can't meet the overwhelming need for oxygen and nutrients at the tissue level, so it's a supply and demand failure, not a primary muscle failure itself.
Okay, now let's move to the central mechanism that drives this entire disease process, the paradox of compensation. You mentioned the body tries to save itself, but it backfires. When the cardiac output dips, the body initiates these powerful short-term survival mechanisms that ironically become the long-term destructive force. How does this cycle begin?
It begins with the body perceiving insufficient blood pressure and flow, thinks, uh-oh, I'm in crisis, I need immediate flow.
Yeah.
And two math neurohormonal systems are immediately engaged.
Just system one, the rapid response, the alarm bell sympathetic nervous system SNS stimulation, the fight or flight.
Yeah. Exactly. This is the massive adrenaline dump. The immediate result is an increase in heart rate and an increase in the force of contraction. This is actually a brilliant short-term fix because it temporarily boosts cardiac output.
But why is this immediate fix so profoundly damaging over the long term, especially if the heart is already struggling to pump effectively?
Because the SNS simultaneously causes intense vasoconstriction throughout the peripheral blood vessels. This tightening of the blood vessels significantly increases the afterload. That's the high resistance the already weakened left ventricle must overcome just to eject blood. So pushing against that sustained resistance dramatically increases the heart muscle's oxygen demand. A failing heart is now working harder, demanding more oxygen, and essentially burning itself out faster. It's like self-cannibalization.
Wow. Okay. And the second system, the long-term volume regulator that ends up kind of flooding the heart, that's renin-angiotensin-aldosterone system, RAS.
Right. When the kidneys sense decreased blood flow, they trigger the RAAS cascade. Angiotensin II is released, which is an even more potent vasoconstrictor than the SNS stimulation. So again, that raises afterload. But critically, the RAAS also leads to the release of aldosterone.
Aldosterone, which is the mechanism for sodium and water retention, right?
Yes. Aldosterone basically tells the body, hold on to every drop of fluid you can. This dramatically increases the circulating blood volume. That raises the preload, the volume stretching the heart muscle before contraction. The body believes, if it pumps more volume, the output will increase. But a weak pump that's overwhelmed by too much volume. It's like trying to inflate a balloon that's already been stretched past its limit. It just causes chronic fluid overload and further strain on the muscle.
And this chronic overstimulation from both systems, the high pressure of afterload and the high volume of preload, leads to a physical transformation of the heart muscle itself.
It does. That transformation is called ventricular remodeling. Chronic RAAS and SNS activation cause myocardial hypertrophy. That means the heart muscle walls thicken and enlarge. Initially, this might actually improve contractility for a short time, but over time, that muscle becomes stiff, disorganized, and less efficient at both contracting and filling. This is the physiological downward spiral into chronic end-stage heart failure.
So the ventricles are constantly stretching and remodeling due to this self-sabotaging fluid overload. There must be a measurable signal that confirms this is happening, something we can test for.
There is, yeah. And it's probably the single most important diagnostic blood marker. Natriuretic peptides, specifically BNP, B-type natriuretic peptide. These are neurohormones released by the ventricles themselves, specifically in response to being stretched by volume overload. They are essentially the body's own attempt to fight back against the RAAS system by promoting vasodilation and diuresis, trying to get rid of fluid.
So an elevated BNP level isn't just a generic sign of heart failure, it's a specific indicator of significant ventricular stretch and fluid overload.
Absolutely. Yeah. The higher the BNP, generally the worse the heart failure and the more severe the fluid status. Clinically, it's critical for diagnosing HF when a patient presents with acute shortness of breath. It helps us differentiate cardiac failure from primary lung issues pretty effectively.
Okay, now that we understand the mechanics, the weak squeeze, the stiffness, the fluid backup, How do these distinct failure types actually manifest in the patient? We need to clearly map the left versus right dichotomy onto the physical signs you might see or the patient might report.
Right. It boils down to this. If you see symptoms related to breathing, cough, and maybe confusion, you absolutely must think left-sided failure first. If you see signs related to swelling and fluid backing up into the systemic circulation, think neck veins, abdomen, legs. You must think right-sided failure.
Okay, let's detail left-sided failure. What are the specific assessment findings that really scream impaired gas exchange? The lung stuff.
The respiratory system is paramount, yes. When you listen to the lungs, auscultation, you hear crackles and wheezes. That's literally the sound of fluid in the alveoli. The patient often reports a persistent, irritating, hacking cough that is notably worse at night, especially when they lie down. The most dangerous acute sign is frothy, pink-tinged sputum. That is the clinical presentation of life-threatening pulmonary edema. The pressure has gotten so high that fluid and even small amounts of blood are pushing directly into the airways. That's an emergency.
And the subjective experience of breathlessness, it also has specific classifications that tell us something about the severity of LVF, right?
They do, yeah. The earliest sign is usually dyspnea on exertion, DOE, shortness of breath only with activity. As it progresses, patients develop orthopnea. That means they can't breathe comfortably lying flat. They have to sleep propped up on, 3 or 4 pillows. The most disruptive is probably paroxysmal nocturnal dyspnea, PND. The patient wakes up suddenly, gasping for air, typically 2 to 5 hours after falling asleep. This happens because the fluid that accumulated in the legs while they were up during the day gets mobilized back to the central circulation when they lie down, overwhelming the failing left ventricle.
Wow. Okay, beyond the lungs, what does reduced forward perfusion look like in the rest of the body?
The lack of output. Well, reduced cardiac output leads to profound systemic issues. Persistent fatigue, generalized weakness, dizziness, and often sudden acute confusion or delirium. That's a really key sign that the brain is not receiving adequate oxygen. On pulse assessment, you might detect something called pulsus alternans. That's where you feel an alternating strong beat followed by a weak beat, even though the rhythm itself is regular. It signals severely depressed mechanical function of the heart. And of course, tachycardia, a fast heart rate as the body tries to compensate.
Okay, now contrast that sharply with the signs of right-sided failure, the hallmark being that systemic congestion.
This is all about visible fluid overload in the veins and tissues. We look for jugular venous distension, JVD, a visibly distended neck vein when the patient is sitting up slightly. Because blood backs up into the portal circulation, the patient will often exhibit increased abdominal girth, maybe a distended abdomen. Fluid can accumulate in the peritoneal cavity, that's ascites, and often an enlarged tender liver, which we call hepatomegaly.
And the most obvious sign, perhaps to the patient themselves, is peripheral edema, the swelling.
Correct. Dependent edema. Swelling in the feet, ankles, and legs, or sometimes the sacrum if the patient is mostly bedridden. What often surprises people, though, is just how much fluid the body can hide before it becomes visible and pitting, where you can press a finger in and leave an indent. The sources note a patient may retain a staggering 7 to 10 liters of fluid, that's 10 to 15 pounds, before we see that obvious pitting edema.
That statistic is crucial. It means if we just rely on looking for pitting edema, we're missing the early, subtle fluid gain by a long shot. Which brings us to the absolutely critical safety priority in tracking these patients. Why is daily weight the single most reliable monitoring tool?
Because the weight measurement captures that hidden, non-pitting fluid gain instantly. Relying on visual edema checks is simply too late. The patient should weigh themselves daily. Same time every morning, usually after avoiding but before breakfast, using the same scale, wearing similar clothing. A rapid gain, even just 2 to 3 pounds in 24 hours, or maybe 5 pounds in a week, is the absolute earliest warning sign that fluid is returning and the patient is heading towards a complication like acute pulmonary edema. It needs immediate attention.
Okay. Beyond the physical assessment, what laboratory or imaging clues help confirm the diagnosis and assess the extent of the damage?
Well, as we mentioned, the BNP is the definitive blood test to diagnose and track severity. High BNP strongly suggests HF. We also look at electrolyte panels very closely, especially sodium, potassium, and calcium. These are often thrown out of balance either by the disease process itself or, more commonly, as a side effect of aggressive diuretic therapy. And because decreased perfusion affects all organs, we also monitor BUN and creatinine to assess potential renal function impairment caused by that low blood flow to the kidneys.
And for a definitive structural diagnosis, to see the heart itself.
That requires imaging. The echocardiogram, or echo, is the gold standard. It's non-invasive, uses ultrasound. It allows clinicians to directly measure the ejection fraction, which is key to distinguishing HFrEF from HFpEF. It also lets us assess chamber size, wall thickness, and look for valvular damage that might be causing or contributing to the failure. Chest x-rays are useful too. They can show a globally enlarged heart that's cardiomegaly and confirm pulmonary fluid accumulation, like effusions.
All right, so we have a diagnosis, we know the structural problem weak pump or stiff pump, and we know the damaging compensatory mechanisms. Now for management. We generally address this using a three-pronged strategy, right? Reduce resistance, afterload, reduce volume, preload, and increase strength, contractility. Let's start with reducing afterload, taking the pressure off the pump.
Exactly. To reduce afterload, we need to promote vasodilation,
Right.
relax those blood vessels. The first-line therapy for almost all forms of heart failure, especially HFrEF, is the drug class designed specifically to block the body's self-sabotaging RAAS system. Those are the ACE inhibitors, ACEIs like lisinopril and enalapril, and the angiotensin receptor blockers, ARBs, like losartan, valsartan.
These are absolutely essential because they stop that RAS cycle we talked about.
Precisely. By suppressing the RAAS, they cause vasodilation, which lowers afterload. They also promote sodium and water excretion over time, which decreases volume or preload. And very importantly, they help limit that damaging ventricular remodeling we discussed earlier. They are cornerstone drugs.
What are the key cautions for the listener about ACE inhibitors specifically? Anything to watch out for?
Two major cautions, yeah. First, the really common side effect is a persistent, nagging, dry cough. It can be quite bothersome for patients. Second, the serious but thankfully rare side effect is angioedema. That's rapid swelling of the mouth, lips, throat, which can be life-threatening, needs immediate medical attention. If a patient can't tolerate the dry cough from an ACEI, we often switch them to an ARB. ARBs work similarly, blocking angiotensin II effects, but they don't typically cause the cough. The angioedema risk, though small, still exists with ARBs too.
Okay, and here's where the cutting edge of medicine comes in. There's a newer drug class that's been a major therapeutic breakthrough, really. It essentially helps the body fight back using its own defense system. I'm talking about ARNIs.
Right, the angiotensin receptor and neprilysin inhibitors. The main one is sacubitril valsartan, brand name Entresto. This represents a significant paradigm shift. It's a dual-action drug. The valsartan part is the ARB. It blocks the harmful effects of angiotensin II, reducing vasoconstriction and remodeling. But the sacubitril part is the real innovation. It inhibits an enzyme called neprilysin.
Okay, so why is inhibiting neprilysin so beneficial in heart failure? What does neprilysin normally do?
Neprilysin's job is normally to break down the body's beneficial hormones,
Sure.
specifically the natriuretic peptides like BMP. So by inhibiting neprilysin, we essentially boost the concentration of the body's own natural defense mechanism against fluid overload and vasoconstriction. We're not just blocking the pathological RAAS system, we are simultaneously amplifying the protective natriuretic peptide system. This combination has shown really superior results in reducing hospitalization and mortality for patients with chronic HFrEF compared to just using ACEIs alone. It's a big deal.
Very interesting. Now, for acute immediate pressure reduction, often in a hospital setting, we rely on classic vasodilators, don't we?
Yes. For acute decompensated heart failure, intravenous nitrates are often used. They work very quickly. They cause widespread venous vasodilation, which reduces preload by kind of pooling blood in the periphery, taking volume away from the heart. And they also cause arterial dilation, which directly reduces afterload. Because they cause profound dilation, though, we have to monitor the patient very closely for sharp drops in blood pressure, hypotension, and manage the severe headaches that can sometimes result.
Okay, moving on to the second prong. Reducing preload, managing the volume overload. This is primarily the domain of diuretics or water pills.
Absolutely. Diuretics are essential, especially for relieving the congestion symptoms of both left and right-sided failure. Getting that excess fluid off is key for symptom relief. For acute severe volume overload, we typically use potent loop diuretics like furosemide, Lasix, or bumetanide. They work aggressively in the kidneys to enhance the excretion of sodium and water, reducing circulating blood volume almost immediately.
When using these really potent drugs, what's the key consideration for patient safety, particularly with our most vulnerable populations, like older adults?
The key is preventing rapid electrolyte shifts and dehydration. Older adults are particularly susceptible to both. Loop diuretics cause significant excretion of potassium, leading to hypokalemia or low potassium levels. This is dangerous because hypokalemia can significantly increase the risk and severity of cardiac dysrhythmias, dangerous heart rhythms. And crucially, low potassium potentiates toxicity from digoxin, a heart drug often used concurrently. So close, frequent monitoring of potassium levels is absolutely mandatory.
Right. And to help manage that potassium balance, we have another class, the aldosterone antagonists. Exactly. Drugs like spironolactone or eplerenone are technically potassium-sparing diuretics. They specifically block aldosterone, which we remember is the RAAS hormone responsible for causing sodium and water retention. So they help get rid of fluid, but tend to hold on to potassium. They are often used alongside ACEIs or ARBs in chronic HF management for their mortality benefits as well. The major risk here reverses, though. Instead of hypokalemia, we worry about hyperkalemia, high potassium, especially when used with ACEIs or ARBs, which also have potassium-raising effects. It's always a delicate balancing act with electrolytes and HF management.
And we can't forget that diet lifestyle are not just secondary considerations. They are core management strategies for controlling preload, that volume piece. Absolutely non-negotiable. Nutrition therapy is mandatory for successful HF management. Sodium intake must be aggressively restricted. Usually the target is 2 to 3 grams per day for mild to moderate HF, and often down to a strict 2 grams per day for severe HF. That's tough for many people. Additionally, if the patient is symptomatic or refractory to diuretics, we often need to restrict fluid intake as well, frequently limited to 2 liters daily. Patient education around reading food labels, understanding hidden sodium sources, it's paramount to their long-term survival and avoiding hospital readmissions.
Okay, now for the final prom. Increasing contractility, making the failing pump stronger. The most historic and perhaps most complicated drug here is digoxin.
Digoxin. Yes, cardiac glycoside. It serves a dual purpose, really. It's a positive inotrope, meaning it increases the force of myocardial contraction, makes the squeeze stronger. But it is also a powerful rhythm modifier. It slows the heart rate and slows electrical conduction through the AV node. It's typically reserved for chronic HF patients, often those who remain symptomatic despite optimal therapy with acarbarine, beta blockers, and diuretics, or those who also have atrial fibrillation.
Given that it has a notoriously narrow therapeutic window, meaning the line between effective dose and toxic dose is very thin, what is the single most important monitoring point for a patient we send home on this drug?
You absolutely must ensure the patient or their caregiver can accurately check their pulse, their heart rate, before taking each dose. And they need clear instructions on when to hold the dose and call their provider, usually if the heart rate drops below a predetermined threshold, often 60 beats per minute. Additionally, given the high risk of toxicity, especially in older patients or those with impaired renal function, everyone needs to be educated on the classic signs of toxicity. These include visual disturbances like blurred or yellow vision, halos around lights, gastrointestinal distress like anorexia, nausea, vomiting, of course bradycardia, slow heart rate, and changes in cardiac rhythm, particularly the appearance of premature ventricular contractions, PVCs. And remember, hypokalemia makes digoxin toxicity much more likely.
Okay. And for acute emergencies where contractility needs an immediate, powerful boost in the hospital?
For acute decompensated heart failure, what we sometimes call cardiogenic shock, we turn to short-term IV infusions of other types of inotropes. These include beta-adrenergic agonists like dobutamine or phosphodiesterase inhibitors like milrinone. These drugs provide that rapid, significant increase in cardiac output and overall perfusion needed to stabilize a critically ill patient. They're usually temporary measures.
Finally, what happens when drugs and diet just aren't enough, when the structure itself needs more direct support? Let's discuss device interventions.
Right. For patients with severe HF, usually with an EF below 35%, who also have conduction delays showing up on their EKG, like a widened QRS complex, we look at cardiac resynchronization therapy, CRT. This involves implanting a special kind of pacemaker system that provides biventricular pacing. It has leads in both the right and left ventricles. It coordinates the contraction of both ventricles simultaneously, making the pump much more efficient mechanically. This can vastly improve symptoms like shortness of breath and significantly improve quality of life for appropriate patients.
And for refractory end-stage disease, when even CRT isn't enough or isn't appropriate, we move to mechanical replacement or assistance.
That brings us to ventricular assist devices, VADs. These are literally mechanical pumps implanted surgically to take over the work of one or sometimes both failing ventricles. They are used either as a bridge to transplant, keeping the patient alive until a donor heart becomes available, or, increasingly, as destination therapy. Destination therapy means the VAD is intended as long-term, life-sustaining support for patients who are too sick, too old, or otherwise ineligible for a heart transplant. The VAD essentially becomes their mechanical heart for the rest of their lives.
And the most definitive surgical option, the ultimate fix, heart transplantation, HT.
A heart transplant remains the gold standard cure for refractory end-stage HF, but it's reserved for patients who meet incredibly strict criteria. Often, this includes having a life expectancy of less than 1 year without the transplant. While it offers the possibility of a cure and a return to a more normal life, post-transplant care is intense and lifelong. It's a life sentence of vigilance, really. The two primary long-term risks are constant threats: acute and chronic infection, due to the necessity of lifelong immunosuppression drugs to prevent rejection, and cardiac allograft vasculopathy, CAV. This is a rapidly progressing, aggressive form of coronary artery disease that specifically affects the arteries of the donor heart. It's a major cause of late graft failure.
Okay, let's shift gears slightly. A large percentage of chronic heart failure cases originate not from an MI or generalized muscle weakness, but from specific structural defects, namely valvular heart disease, VHD. The heart's flow depends on four tiny, perfectly functioning one-way doors, the valves. And if they become stiff, narrowed, stenotic, or leaky, regurgitant, the entire system eventually breaks down into heart failure.
That's a perfect definition.
Yeah.
VHD is fundamentally a structural problem that guarantees a flow problem, which then leads directly to heart failure symptoms down the line. Understanding the etiology, the cause, is key. Many cases of mitral and aortic stenosis that we see today trace back to the scarring left by rheumatic carditis.
Rheumatic carditis, which is an inflammation that occurs following sensitivity to a group A streptococcal infection, like untreated strep throat, often years or even decades earlier.
Precisely. That initial inflammatory process damages the delicate valve leaflets, leading to thickening, fibrosis, and eventual calcification over many years. Let's look at two key valve problems as examples. First, mitral stenosis.
Stenosis meaning narrowing, so this is the narrowing of the mitral valve, the one between the left atrium and the left ventricle.
Correct. The narrow opening obstructs the flow of blood from the LA into the LV during diastole. Pressure immediately builds up in the left atrium. That pressure then backs up into the lungs, causing pulmonary hypertension. And eventually, this causes the right side of the heart to work much harder against that high pressure. The symptoms directly reflect this backup. Severe DOE, dyspnea on exertion, palpitations, maybe atrial fibrillation due to the stretched atrium, and chronic pulmonary congestion symptoms.
Okay, now contrast that with aortic regurgitation, also called aortic insufficiency. The aortic valve is the main exit door for oxygenated blood going out to the body.
Right. Aortic regurgitation means the aortic valve leaflets don't close tightly during diastole, when the ventricle is relaxing. This causes a large volume of blood to rush backward from the high-pressure aorta right back into the left ventricle. The LV has to compensate for handling this extra regurgitant volume, plus the normal incoming volume from the left atrium. It does this by dilating significantly and becoming severely hypertrophied, thickened over time.
And this backflow creates a massive swing in blood pressure between systole and diastole, leading to the really defining assessment finding of aortic regurgitation, doesn't it?
Yes, absolutely. The patient will often have a characteristic bounding arterial pulse, sometimes called a water hammer pulse. This results from a very high systolic pressure, because the LV is ejecting that massive compensatory volume, combined with a severely diminished diastolic pressure caused by the blood leaking back out of the aorta into the LV. This creates an extremely wide pulse pressure, the difference between systolic and diastolic, which the clinician feels as a strong, bounding, collapsing beat. You might also see head bobbing with a heartbeat in severe cases.
So how do we manage VHD? What's the non-surgical approach generally look like?
Well, non-surgical care basically mirrors heart failure management. It's about controlling the symptoms caused by the valve defect. So aggressive drug therapy using diuretics to manage fluid overload, beta blockers maybe to control rate, and vasodilators like AC inhibitors to reduce the workload on the ventricle. It's symptom management, not fixing the valve itself.
But the crucial priority, especially for any patient with a known structural valve defect, is infection prevention. This is huge.
This cannot be overstated. Any patient with a defective or replaced heart valve is at high risk for infective endocarditis, i.e., bacteria circulating the bloodstream just love to colonize damaged or artificial valve surfaces. Therefore, the patient absolutely must receive prophylactic antibiotics before any invasive procedure that could introduce bacteria into the bloodstream. The most common example is dental procedures, even routine cleanings. But also other surgeries, bronchoscopy, etc. Preventing IE is critical.
Okay. And if medication isn't enough, and surgery is required, the decision often lies between repairing the existing valve or replacing it entirely.
Right. Reparative procedures, things like valvuloplasty, repairing the leaflets, commissurotomy, which is cutting fused leaflets apart in stenosis, or annuloplasty, repairing or reinforcing the valve ring, are always preferred when technically possible. That's because they preserve more of the patient's native valve function and, importantly, often avoid the need for lifelong, intense anticoagulation therapy.
But if the damage is too extensive for repair, then replacement is necessary. And that means choosing between a mechanical or a biologic valve. What are the major clinical trade-offs there?
The trade-offs are significant and really depend on the patient's age, lifestyle, and ability to manage medication. Mechanical prosthetic valves are incredibly durable. They can potentially last a lifetime. But they are made of artificial materials that inherently introduce a huge risk of blood clot formation, thromboembolism. This necessitates lifelong anticoagulation therapy, typically with warfarin, Coumadin. This isn't trivial. It demands constant blood monitoring with INR checks, frequent dose adjustments, and a strict diet where the patient must maintain consistent intake of vitamin K, found in leafy green vegetables, because vitamin K directly counteracts warfarin's action. Too much or too little can lead to clots or bleeding.
Okay, so mechanical means durability but lifelong anticoagulation hassle. What about biologic tissue valves, often xenografts from pigs or cows?
Biologic valves are generally preferred for older adults or those who can't reliably manage anticoagulation. Their main advantage is a much lower risk of clotting. Therefore, they do not typically require lifelong anticoagulation beyond maybe the first few months post-surgery. However, the big downside is durability. They are less durable than mechanical valves. They eventually calcify, stiffen, and degenerate over time. This usually means they require repeat replacement surgery, on average every 7 to 15 years, depending on the valve type and location. So it's a trade-off. Less anticoagulation hassle now, but likely more surgery later.
The conditions we've reviewed, heart failure, valvular disease, often lead to acute, potentially life-threatening complications. Let's look at two critical inflammatory and mechanical emergencies: infective endocarditis, which you mentioned, and the dramatic complication that can arise from pericarditis.
Right. Infective endocarditis, i.e., as we touched on, is a microbial infection, usually bacterial but sometimes fungal, of the endocardium, the heart's inner lining. The infection typically deposits on the heart valves, especially if they're already damaged or artificial, and forms these clumps called vegetations.
And these vegetations aren't just inert masses, they are the source of the real danger, aren't they?
Precisely. There are collections of fibrin, platelets, microbes, and they are notoriously prone to fragmenting or embolizing, breaking off and traveling in the bloodstream. If the infection is on the left side of the heart, affecting the mitral or aortic valve, those emboli travel systemically. They can cause strokes, block blood flow to the kidneys, renal infarction, the spleen, splenic infarction, or block arteries in the arms or legs. If the infection is on the right side, tricuspid or pulmonic valve, the emboli travel directly to the lungs, causing pulmonary emboli or infarction.
Beyond the obvious signs like fever, chills, and maybe a new heart murmur, what are some unique assessment findings that specifically suggest this infection might be embolizing systemically?
We look for the subtle but telling peripheral signs of microemboli. These include splinter hemorrhages, which are tiny linear black streaks appearing under the fingernails or toenails. Also, petechiae, which are pinpoint reddish-purple spots caused by bleeding under the skin. They often appear on the trunk, mucous membranes, like inside the mouth or eyes, or extremities. Other classic signs, though less common now, include Osler's nodes, painful nodes on finger soles, and Janeway lesions, painless spots on palm soles. Heart failure, however, remains the most frequent and life-threatening complication of IE because the infection can rapidly destroy the valve structure itself, leading to acute, severe regurgitation.
And the treatment? It requires a significant commitment from the patient.
It certainly does. IE requires extended courses of high-dose 4V antimicrobial therapy, usually lasting 4 to 6 weeks, sometimes longer. Often, patients need specialized IV access, like a PICC line, and may even be discharged home to continue receiving IV antibiotics from a home health nurse or infusion center. Surgery, usually valve replacement or repair, is reserved for cases where antibiotic therapy fails to clear the infection, if there's resulting severe heart failure due to valve destruction, or if there are large mobile vegetations that pose a very high risk of causing major emboli.
Okay, let's shift our focus now to the protective sac around the heart, the pericardium. Acute pericarditis is inflammation of this sac. What typically causes it?
It can be caused by various things. Infections, viral or common, autoimmune diseases, kidney failure. It can also occur after a heart attack, that's called Dressler syndrome, usually weeks later, or even after cardiac surgery, known as post-pericardiotomy syndrome.
The primary diagnostic clue is usually the chest pain, which is quite distinct from typical angina or MI pain, right?
Very distinct. Tell us what makes the pain so unique to pericarditis. How does it present?
The pain is usually substernal, felt behind the breastbone. It's often described as sharp, stabbing, or grating in quality. But crucially, it's often pleuritic, meaning it worsens dramatically on deep inspiration or coughing. And importantly, it's typically postural. It's almost always relieved significantly by sitting up and leaning forward, and gets worse when lying flat. This positional nature is a key differentiator. On auscultation, when listening to the heart, we might hear a characteristic leathery grating sound. The pericardial friction rub caused by the inflamed layers of the pericardium rubbing against each other with each heartbeat.
Okay, now if that inflammation causes fluid to accumulate rapidly within that pericardial sac, we can enter one of the most dangerous mechanical emergencies in all of cardiac care, cardiac tamponade.
This is a true medical emergency. Tamponade occurs when fluid, it could be blood after surgery or trauma or inflammatory exudate, fills the pericardial sac. Even a relatively small amount, sometimes as little as 20 to 50 milliliters, if it accumulates rapidly, can be enough to compress the ventricles. This compression prevents the heart chambers, particularly the ventricles, from filling properly during diastole. This leads to a catastrophic drop in cardiac output and potential cardiovascular collapse.
How do clinicians quickly recognize that this life-threatening fluid compression is occurring? What are the key signs?
We look for the classic signs often called Beck's triad. First, jugular venous distension, JVD, because blood can't get into the compressed right heart, causing severe systemic backup. Second, muffled or distant heart sounds on auscultation, because the fluid surrounding the heart dampens the sound transmission. And third, hypotension, low blood pressure, due to the critically reduced cardiac output from impaired filling. The definitive mechanical finding, if you can measure it, is pulsus paradoxus. That's an abnormally large drop, more than 10 millimeter HGN systolic blood pressure during normal inspiration. It reflects the exaggerated interdependence of the ventricles when compressed.
And the life-saving intervention. What needs to happen immediately?
Emergent pericardiocentesis. A needle or catheter is inserted, usually under ultrasound guidance, into the pericardial space to physically withdraw the accumulated fluid. This instantly relieves the pressure on the heart, allows the ventricles to fill properly again, and can restore cardiac output dramatically and immediately. It's life-saving.
So we've covered the immense complexities of the failing heart, from the body's own damaging compensation to the acute interventions needed. Now we really must address the reality of patient life outside the hospital walls. The goal of modern cardiac care isn't just about surviving the acute event, but preventing recurrence. Hospitals are intensely focused, driven by quality metrics and finances, on reducing those costly 30-day readmission rates for heart failure.
This focus is absolutely essential, you're right, and success hinges almost entirely on comprehensive patient education and their ability to engage in effective self-management at home. Readmission rates are a major quality metric. For example, core measures mandated by agencies like CMS include ensuring the patient is prescribed both an ACE/IRB and a beta blocker at discharge, if appropriate for HFrEF, and also ensuring that a follow-up appointment with their provider is scheduled within 7 days of leaving the hospital. Early follow-up is key.
But ultimately, the responsibility lands squarely on the patient and their family, making effective, clear, and repeated education completely non-negotiable. How are these complex key teaching points distilled for long-term adherence? How do we make it stick?
We need to use clear, simple frameworks that patients can remember and use daily. One common teaching method is often summarized by the acronym AWDS. What does that stand for?
MWDS is a great tool. M is for medications, knowing the names, dosages, timing, purpose, and side effects of all their pills. A is for activity, understanding their limits, balancing activity with rest, energy conservation techniques. W is for weighing daily, our absolute safety priority, monitoring for fluid retention. D is for diet, strictly adhering to sodium and, if prescribed, fluid limits. And S is for symptoms, knowing exactly which signs and symptoms indicate worsening HF and require immediately notifying their provider.
Okay, let's reiterate that critical symptom alert piece, since missing these signs can lead directly back to the ER or the ICU. What are the non-negotiable action alert signs a patient must report immediately?
Any rapid weight gain, we define this specifically. A gain of 2 to 3 pounds in a 24-hour period, or 5 pounds or more in 1 week. That is almost certainly fluid accumulation and needs intervention. Other serious indicators include developing cold symptoms like a cough or congestion that lasts for more than 3 days, increasing shortness of breath, especially at rest or with less activity than usual, waking up breathless at night, PND, increased swelling in the ankles, feet, or abdomen, or just a severe sudden decrease in the ability to perform regular daily activities, a sharp drop in exercise tolerance. These all signal imminent decompensation and require prompt medical attention.
Finally, in this deep dive, we absolutely must acknowledge the systemic disparities highlighted in the source material regarding health equity and cardiac care. This is a critical issue.
The data is unfortunately very clear and consistent. Black and Hispanic adults are disproportionately affected by heart failure, both in terms of incidence and severity. And more tragically, the mortality burden, the death rate for heart failure, is demonstrably greater in Black patients compared to white patients, even after accounting for other factors.
And this inequity extends right through to the most advanced treatments, like end-stage therapy and heart transplantation.
Yes, significant disparities persist in access to advanced therapies like VADs and heart transplantation rates, as well as post-transplant outcomes between racial and ethnic groups. Recent revisions by UNOS, the United Network for Organ Sharing, which governs organ allocation in the U.S., aim to address some of these ethical and clinical failures by establishing policies explicitly designed to foster greater equity in organ distribution. But improving outcomes for diverse populations demands more than just policy changes. It requires a conscious focus on interprofessional collaboration, addressing implicit bias within the healthcare system at every level, and ensuring that complex management plans are not only evidence-based but also culturally sensitive, accessible, and feasible for all patients regardless of their background.
So to try and synthesize our deep dive today, we started with the really paradoxical breakdown of the heart, where the body's own self-preserving mechanisms, the SNS and the RAA systems, end up actually destroying the muscle through remodeling and volume overload.
And then we mapped the resulting congestion either to the lungs, causing breathing problems and left failure, or to the body, causing swelling and right failure. And we really emphasize why a simple tool like the daily weight check trumps almost all others in terms of early warning and safety monitoring at home.
Right. And then we dug into the management. The drugs to reduce afterload, like ACE inhibitors and ARNIs, the diuretics to manage preload, the tricky role of digoxin for contractility, and the advanced devices like CRT and VADs.
Yeah, and what stands out most profoundly to me after all that complexity, the surgical precision, the sophisticated drug selection, the device implantation, is that success ultimately translates back to the patient's ability to meticulously manage their chronic condition day by day, tracking their weight, sticking to the diet, taking meds correctly, knowing when to call. That daily vigilance is truly the key to preventing disaster and staying out of the hospital.
Absolutely. And speaking of advanced intervention and profound physiological complexity, we ended with the definitive, though rare, cure for end-stage failure, heart transplantation. As a final provocative thought for you, our listeners, let's return to the massive physiological implication of receiving that new heart.
The transplanted heart is denervated. That's the key physiological difference. It is physically disconnected from the body's entire autonomic nervous system. The sympathetic nerves, the vagus nerve, the pathways that normally carry adrenaline signals, all severed during the transplant surgery.
Wow. So what does that profound disconnection actually mean in practical terms for the patient living with that new heart and for the clinicians monitoring them?
Well, it means the new heart doesn't respond to stress, pain, exercise, or traditional neural signals the way a native heart does. It's fundamentally different. For instance, the resting heart rate of a transplanted heart is often elevated, maybe 90 to 110 BPM, because the vagal nerve brake is gone. The heart rate increases very slowly during exercise, relying on circulating hormones rather than nerve signals, and it decreases slowly afterward. Crucially, the patient often won't experience classic chest pain, angina, even if the donor heart's arteries develop problems like CAV, because the pain-sensing nerves have been cut.
So if the transplanted heart is struggling, perhaps due to rejection or CAV, the patient's typical warning signs like chest pain or rapid heart rate changes won't be there.
Exactly. It forces clinicians and patients to rely on other, sometimes more subtle, non-traditional signs like drops in exercise tolerance, new fatigue, shortness of breath, or fluid accumulation to detect problems. It really reveals just how reliant we normally are on that intricate brain-heart connection for detecting trouble and regulating function in everyday life, the complete fundamental shift in physiological assessment and patient experience.
A perfect thought to end on, reminding us that even with a seemingly perfect mechanical fix like a transplant, the body's incredibly interconnected systems present an ongoing, fascinating challenge. Thank you for diving deep with us today on these critical cardiac conditions.
Always a pleasure. A really important topic.